Today I'm going to talk about risk for heart attack or myocardial infarction, and specifically what you can all do to lower this risk. I have no disclosures relevant to this talk today. I'm going to try to specifically target my talk to the patients in the audience and try to give you some practical points to act on, and I'm very happy to take questions at the end. One thing you'll also notice as I go through this is that a lot of the material I'll be talking about today builds on and reinforces some of the points you've heard in earlier talks and that you'll hear in subsequent talks. So there will be three objectives to this talk. The first is understanding atherosclerosis, which is the major cause of heart attack. The second is how each of you can understand your risk of heart attack. And last, and probably most important, what you can do to lower your risk. I'll try to put this in real terms, and so I'll talk about spectrums of risk, and these are examples of patients that I've seen in the last year in my preventive cardiology practice, all of whom have some form of cardiovascular risk or risk for heart attack. And that ranges the gamut from a woman in her 30s who's very fit, runs 5 miles a day, just has mildly elevated cholesterol, but recently had the unfortunate news that her father, who was similarly healthy, died suddenly of a heart attack. She wants to know, well, what's her risk? A man in his 40s with hypertension, high cholesterol, obesity, cigarette smoking, who says he's noticed that he's been out of breath when walking up flights of stairs. What about his risk? And lastly, what about a man in his 50s with hypertension, high cholesterol, obesity, prediabetes, and cigarette smoking, who works at nights and does no exercise? So, unfortunately, deaths from cardiovascular disease remain the leading cause of death in this country. What this graph shows is the deaths in thousands over decades. And on the one hand, this looks relatively promising in that the death rate has leveled off over the past few decades, and that's largely a result of some of the new medical therapies and technologies you've heard about today. But you could also look at this and say, look how many people continue to die from cardiovascular disease, and why can't we do better? So if you look at heart disease, the American Heart Association has put out these 7 measures of ideal cardiovascular health with a goal that by the year 2020, the majority of Americans will begin to approach ideal cardiovascular health in each of these metrics. And the metrics are smoking, body mass index, which is a measure for overweight and obesity, physical inactivity, healthy diet, cholesterol, blood pressure, and blood glucose. One thing I'd like to highlight is that some of the risk factors that we typically think of, like cholesterol, blood pressure, and glucose, a large proportion of adults in this country are actually meeting ideal or intermediate success in their management. Where we're doing less well, though, is in managing problems related to body weight, inactivity, and healthy diet. And I think if we don't do something to change this, these will be some of the major drivers, along with cigarette smoking, for heart disease and heart attack going forward. So there are numerous causes for heart attack or myocardial infarction, but the most common is a process called atherosclerosis. And this is just a schematic to show you what atherosclerosis actually is. It's a process whereby a plaque forms in the blood vessel, and this is due to a combination of cholesterol deposition as well as inflammation, which you heard about earlier, in the blood vessel wall. And what we worry about is when this plaque ruptures, it can trigger a process called thrombosis, or a blood clot, which can result in a heart attack or even death. And so how we manage atherosclerosis really depends on a person's risk factors and whether or not they've ever had symptomatic atherosclerosis. For the purpose of today's talk, I'll focus on people in these groups. So in general, all patients, whether or not they're known to have atherosclerosis, can benefit by controlling risk factors such as smoking, diet, and exercise. Those at higher risk, and I'll get to this in a little while, can benefit more specifically from medications like statins, aspirin in some cases, being mindful of the associated bleeding risk, and other medications such as ACE inhibitors. So I'd like to turn now to reviewing the risk factors for atherosclerosis, and I think it helps to divide these into three categories. Those that can't be changed, so you're sort of stuck with them. Those that can be changed, and then other risk factors that are hard to really quantify their exact impact on atherosclerosis. So what about risk factors that can't be changed? Age greater than 65, male sex, with the understanding that risk in women increases following menopause, family history, and certain race and ethnicity. Now, I mention these factors that can't be changed not to suggest that if you have these risk factors you should do nothing, but if you have these risk factors, it's reason to be even more aggressive at targeting some of the factors that can be modified. So let's turn to those. Smoking. So the risk of heart attack is 2 to 4-fold higher in smokers, and that includes people who smoke pipes and cigars, people with high cholesterol, and we'll come to that a little bit more about what exactly that means, those with elevated blood pressure, those with diabetes, and one alarming statistic is that 65% of people with diabetes, their ultimate cause of death is cardiovascular disease, physical inactivity, and overweight and obesity. There are other risk factors as well that undoubtedly contribute to heart disease, but which are harder to really quantify, and I'll just mention them here. Stress is an important factor. Alcohol, which Dr. Goldhaber just spoke about, and specifically more than 2 drinks a day in men and more than 1 drink a day in women. Poor diet and nutrition. Sleep apnea, and inflammatory diseases like lupus and rheumatoid arthritis all increase the risk of heart disease. So there are many different ways to actually predict and quantify a person's risk for heart disease, none of which are perfect. One of the most well-known is something called the Framingham risk calculator, which any of you can get by going online. And I'm going to show it here, and then I'll go through an example of one of the patients I introduced at the beginning. So the Framingham risk calculator allows a person to estimate their 10-year risk of having a heart attack. And the things that go into that are a person's age, gender, total cholesterol, HDL, cholesterol, which we usually think of as the good cholesterol, whether or not that person is a cigarette smoker, what their systolic blood pressure is, and whether or not that person is currently on any blood pressure lowering medications. So here's an example. This is a patient who came to see me not too long ago. A 58-year-old man had a total cholesterol of 255, which is high, an HDL cholesterol of 30, which is low. He was an active cigarette smoker. His systolic blood pressure was 160 millimeters of mercury, and this was on medications. I should also mention, in addition to these factors, that he was doing no exercise and was obese. So if you feed those numbers in, what you can actually see is that his risk of having a heart attack over the next 10 years was 30%, which would put him in the high-risk category. So how can we lower the risk of someone like this or a similar patient? It's fairly straightforward. To start, one way is by addressing the ABCs. So very, very important to avoid and eliminate tobacco. Second, equally important to become more active, and you'll hear about this in one of the subsequent talks. And also another topic coming up is to choose good nutrition. So in terms of reducing risk, I'll talk first about lifestyle factors and then afterwards about some medical interventions. So I mentioned cigarette smoking. It is absolutely critical to stop smoking and also to avoid secondhand smoke. One thing that's gotten a lot of attention in the press lately is the new electronic cigarettes. Some patients are under the impression that if they switch to an electronic cigarette, the risk is 0. I think that still needs to be studied, but almost certainly is not true. So ideally, the goal should be to avoid all forms of all smoking. Secondly, improve nutrition. How can you do that? You can reduce saturated fats, trans fats, and cholesterol, and watch calories. Also very, very important to become more active And the goal in an ideal world would be to aim for at least 30 minutes of activity at least 5 days a week. Also, a person wants to aim for a healthy weight, and that can be assessed either by body mass index or by following a person's waist circumference, which is a measure of the amount of fat they have in their belly, which is particularly bad for you, reducing stress, and limiting alcohol. I'll now turn to some of the medical interventions. So one of the most important medical interventions is to target cholesterol, and specifically targeting the LDL or bad cholesterol. The standard guidelines right now suggest targeting an LDL cholesterol below 160 if a patient is low risk, below 130 if intermediate risk, and below 100 if high risk. For those at highest risk or prior heart attack, we target even lower levels below 70. Now, one thing I want to point out is that these are from the current guidelines. There are new guidelines coming soon, and I think many people expect that the target cholesterol levels will be even lower. We evolved to have cholesterols far, far lower than this. So what we're now calling a low cholesterol of around 100 is probably still much higher than our ancestors lived with. In addition, it's important to try and target an HDL or good cholesterol above 40 in men and above 50 in women. And one of the best ways to do this actually is with weight loss and exercise. Similarly, weight loss and exercise will help target triglycerides below 150. Also important to try and lower one's blood pressure, and there is a stepwise relationship between blood pressure and risk of heart attack, and I think it still remains to be defined what the optimal blood pressure is in different patient populations, but in general we want to try and target a blood pressure below 120/80. And also very, very important to manage your diabetes. So these are very broad points, and I've chosen to be deliberately broad because a lot of the specifics about how these risk factors are targeted and how aggressively they should be targeted really depends on an individual patient. But these are some of the things you might want to talk about with your doctor. So first of all, if you're smoking, it's very hard to quit smoking, and that doesn't mean you've failed if you've been unable to do it. There are now numerous ways using both medications and other interventions to help a person stop smoking. And so if you continue to smoke, ask your doctor for help with that. Secondly, I think every person in this room should know what their cholesterol profile is, and along with that, should be asking their doctor if they should be on a cholesterol-lowering medication. What are the pros? What are the cons? Along with that, a person should know his or her typical blood pressure and should be asking their doctor if it's elevated, should they be on a blood pressure-lowering medication. And then lastly, this sort of reinforces a point that was made earlier, should someone be on a daily aspirin to help prevent heart attack or stroke? And this is a very complex question, as you've heard earlier. I think in the past, the simplistic view was that all adults, or at least men over a certain age, should be on a daily baby aspirin, but it's probably not that simple. And the benefits of aspirin need to continually be balanced with the risks of bleeding associated with it. So let me just give you an example of risk reduction put into practice. The man I spoke to you about earlier who had a 30% 10-year risk, I've been following him over the past year, so he's now 59. He has made efforts to diet and exercise, and with that has also started a cholesterol-lowering medication, and his total cholesterol has come down to 200, and his HDL, or good cholesterol, has come up from 30 to 36. With the aid of a medication, he has now quit smoking. His medications were adjusted, and so his blood pressure has now been reduced to 125 millimeters of mercury. And with that, his 10-year risk of heart attack has come down from 30% to 13%. So he's certainly still at risk, but this is a fairly significant risk reduction. And if you imagine this applied to a population of patients, you could really see there would be substantial benefit. So when you leave today, I think it's important to have some sort of an action plan. And the American Heart Association has an excellent website, and they sort of break this down into what they call Life's Simple 7. And so the goals are specifically to try and get more active, eat better, lose weight, stop smoking, control cholesterol, manage blood pressure, and reduce blood sugar. And with that, I'm happy to take any questions.
Thank you, Paul. That was fantastic. Questions for Dr. Cohen?
I promise you it's going to be real simple. My name is Pat Augustine. I had a heart attack back in July this year. Before I had my heart attack, I was always snoring, and the doctor said it's probably sleep apnea. Since I had the heart attack and I had 3 stents put in, I'm not snoring anymore. Is there any connection to snoring and cardiovascular disease? Make sense? Or
yeah. So that's an excellent question, and snoring is one of the main signs that a person might have sleep apnea. And for a long time, people thought that sleep apnea was really just a problem for whoever had to share a room with a snorer. But it's actually a serious problem for the person with sleep apnea. And we're appreciating more and more the risks that sleep apnea confers towards heart attack, stroke, and even death. And so I think in terms of the first part of your question, all patients at risk for sleep apnea or who have signs of sleep apnea should talk to their doctors about a sleep study and about treating it. In terms of the snoring having gone away, it could be that some of the changes you may have made after your heart attack have helped address the sleep apnea, but I think it's also important to realize that snoring is just one component. And so I think some people wrongly assume that if their snoring is softer or gone, that they no longer have sleep apnea, and that's not necessarily true. So I think it's worth investigating and following up on.
Okay. Thank you very much.
Thank you.